Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts. Hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, and welcome back to the MedEvidence podcast. I'm your host, Dr. Eric Schramm, sitting in for Dr. Koren today. For those who don't know me, I'm a board-certified family physician and longtime clinical research investigator with the Encore Clinical Research Group. I'm also a seasoned cannabis physician involved in helping people following their healing journey with medical marijuana. I'm very excited to be here today with one of my favorite dermatologists, is Dr. Michael Bernhardt. Dr. Bernhardt and I go back many, many years. He never gets tired of hearing the story about me being that family practice resident.
One of the smartest they ever had.
Well, he's very generous, but recalling a very, very good experience with my clinical dermatology rotation. And Mike was a fantastic teacher, of course, but importantly, he was a really good role model, demonstrating empathetic patient-centered care. I learned a lot from Mike. So
Thank you.
I and still do. I get a opportunity to work with you every Friday afternoon, which is another extension, I would think, of your teaching, which we can talk about your background. So to those who don't know, Dr. Michael Bernhardt, he's been practicing clinical dermatology for several decades. In addition, he is a very seasoned clinical investigator, as I've alluded to, and I've had the pleasure of collaborating on a number of studies with Mike. In addition, he's got extensive background in clinical education and medical education, and just recently completed his 3-year stint at the Florida State University teaching residents. And that is no small task, I would say. So you're kind of this triple threat in the clinical world of research, clinical practice, and as well as doing your academics. So one of the things we're excited to be talking about today is Hidradenitis Suppurativa. Now, that's a mouthful, so we like to refer to it as HS. And perhaps you could give us a little idea about HS 101.
Sure, I'd be glad to. But before we start on HS, I just got to tell you, this stress ball is the perfect stress ball for a dermatologist because it's called molecule, MOLECOLL, molecule. Not molecule, but molecule. So I highly recommend this for all your stressed out dermatologists.
There we go.
Very good. All right. So we're going to talk a little bit about HS. So the cool thing in the last 10 or 15 years that we've done is there used to be what I used to call the three-headed monster in dermatology. We'd have people with severe psoriasis, severe eczema or atopic dermatitis, and hidradenitis. And we've really come a long way, largely because of some of the research that's done in clinical facilities like this with clinical trials. We had a lot of patients on the clinical trials for psoriasis. We did some of the phase 2 and phase 3s for atopic dermatitis. Now we're dealing with the last of the three-headed monsters, and we're just now bringing it into the modern era of treatment with things other than antibiotics. So hidradenitis. All right, so let's if you guys know me, I can't free associate and think without being able to draw, because it just kind of facilitates a whole thought process. So this is the skin. The epidermis has several layers to it. And then within the epidermis, you've got the hair follicle, and feeding into the hair follicle is the oil gland, what we call the sebaceous gland. This is a little dermal papillae, which is a bunch of blood vessels and collagen, which has all these little chemical intermediators that we call cytokines, which are like cell signals, that stimulate the hair shaft to grow, okay? And at the same time that the hair shaft is stimulated to grow, basically the same cells that line the epidermis will also line the follicle.
And some people are more follically challenged than others, I understand, and
Preaching to the choir.
I know. I was going to say maybe that's the next four-headed monster to tackle, right?
If I say here today, gone tomorrow, I know from personal experience. But so this is the oil gland, and what basically happens in hidradenitis. Let's go clinical first before I draw. The average person with hidradenitis starts with lesions typically in their teens, and it'll go for 8 to 10 years before that person's diagnosed. These lesions are normally found in what we call the fusion planes: the armpit, the area under the breast, the crease of the groin, and the perianal crease. That's the usual hotspots. And what will happen is the person will present to their family, they'll present to the emergency room or urgent care with boils. And they'll get treated as boils. They get lanced, they get drained, they get put on an antibiotic. And this will go on for typically 8 to 10 years before someone puts it together and says, hey, wait a minute. We've got the same lesions recurring in similar areas that are leaving tracks and scarring, leaving draining areas, and it's always in that same spot, the armpit, inflammatory crease, boom, it's hidradenitis.
No.
And that's really the clinical hallmark
Right.
of hidradenitis. Recurrent, quote-unquote, abscesses and boils, same area, goes on for a long time. Now, why does it happen? Well, these cells that line the follicle, they swell up and form plugs, and there's a lot of things that these cells will overreact to. Smoking is one. Nicotine is one. Hormones, testosterone, progesterone can drive it. Metabolic syndrome, morbid obesity can drive that. We can get into the more details about that in a little while. But those are the clinical drivers.
All right. Now, seen, I understand, a little more so in women than men. Is that your typical experience?
Yeah, my experience is it's mostly females. When you look at some of the clinical trials, a lot of clinical trial data will be skewed. A lot of them, is predominantly Caucasian community in clinical trials, but my own personal experience, overwhelmingly, the African-American community is overrepresented with this condition. And usually has several underlying comorbidities, obesity, diabetes, that tend to drive this. Metabolic syndrome, non-alcoholic steatohepatitis. We tend to see all that kind of overlap.
How would you compare or contrast this to acne?
So in the old days, i.e. back when I was a resident, we used to call it acne inversa, right? Because it's not in the face or back, it's in these inverse areas. And in certain ways, it overlaps. But when we start talking about the cytokine soup in hidradenitis is a little bit different than what we see in acne, of course. They're both neutrophil-mediated conditions, right? They're both due to overexcitation, shall we say, of the oil secretion apparatus. But the cytokine milieu is a little bit different.
Okay. We can talk a little bit more about that a little bit later. But also to underscore, in primary care, we treat a lot of this, and, this can be really devastating to patients. I mean, it's painful, scar formation, very poor quality of life for those patients with this.
I've seen people's lives totally destroyed, when you start talking to people about it. Patients cannot marry. They can't have a normal dating life or sex life. They have to be judicious about what kind of work they do. Because if, God forbid, you go in and get a great new corporate job and you have a bunch of these abscesses that decide to spontaneously open and drain and release a foul odor while you're in the middle of a board meeting, it's going to be tough for maintenance. So in terms of the areas of involvement, right, it's always, and forgive my drawing, I'm not a very good artist, but it's armpits, right, inflammatory crease, genital area, and the gluteal crease. And sometimes they'll be associated with it. Sometimes they'll also have an associated pilonidal cyst. So when you see recurrent crops of abscesses in that area, I mean, bang, that's hidradenitis to prove otherwise.
Right. And back 20 years ago, as a rotating resident, we might have been looking at, topical compresses, oral antibiotics. I won't say that's primitive. Maybe looking back now, it seems kind of sort of primitive, but we just didn't have a whole lot to offer those patients.
We didn't, and really up until 2-3 years ago, it was the same thing. Oral antibiotics, particularly doxycycline, because it drives down some of these enzymes called metalloproteinases that upregulate inflammatory response. So we'd use a lot of doxycycline. We would use metformin to block the insulin growth factor 1 pathway. Humira was a huge first step in the right direction because Humira, which is a TNF inhibitor, was the first FDA-approved biologic that had some impact.
Right.
And what we do is we quantify these lesions in terms of what's called a HiSCR, HISCR, which is hidradenitis remediation, basically. And what are we looking at? We're looking at a reduction of abscesses, nodules, and tracts. And so if you have a 50% reduction of these abscesses and nodules, you've achieved what they call a HiSCR 50, 75% HiSCR 75, and so on and so forth. So Humira was great because it was the first drug that gave us a HiSCR 50. It actually worked.
Wow.
It was wonderful.
Mm-hmm.
And then when the pandemic hit, the FDA got so slammed and so overworked with things related to COVID that a lot of non-COVID things got pushed on the back burner. So several drugs that we were waiting for approval. One was secukinumab, which is marketed as Cosentyx, and bizakizumab, which is Benzelex, which are both 17A inhibitors, finally got the FDA approval. And these drugs are kind of putting us in the modern era now.
Right. And you were already talking about some of the bad actor cytokines that we often talk about when we have time on on Fridays when we have an opportunity to do that. But getting back to the original Humira as a monoclonal antibody was a real game changer, and we talked about that also in treating psoriasis.
It was a huge game changer.
Right. And then consequently, do you see the newer agents as the new and improved version of Humira, or just a different version?
Yeah, some really cool. Drop my phone. Sorry. That makes for great podcasting, great radio on GP. Sorry, but it didn't break. These things are a game changer because, there's several inflammatory mediators. I call them like the three or four amigos or the three musketeers. They always run together, and wherever they run, trouble follows, right? So whether you talk about interleukin-6, whether you talk about TNF alpha, whether you talk about 17A, 17A alpha, or the 17AF heterodimer, wherever these guys go, trouble follows.
Right.
And, we knew that 17A played a role in the inflammatory cascade in HS. And some of the newer data is showing that 17A, while being a major driver, 17F and 17AF heterodimer may play even more of a role of amplification. Now, with that being said, the specific mechanism hasn't been quantified. So some of this is still kind of speculative based on own personal interpretation of the data, But we seem to know that this molecule, 17A, 17F, 17AF, really seem to upregulate the inflammatory cascade.
Right, and maybe more so than TNF.
TNF is upregulated.
Right, but maybe 17A and F being a more potent stimulator, would you say, as a better target for treating in terms of its anti-inflammatory responses?
I think it's emerging as it's in the latest literature. It's really kind of evolving into the given a choice, that would be my first choice to target.
Okay.
In terms of mediators. Now, the problem is that, this from practicing medicine, that if the patient has certain comorbidities, it carves out certain classes of drugs, which is why it's good to have both the TNF inhibitors as well as the 17A or 17AF inhibitors, because the person may have certain premorbidities that prevent us from using one drug or the other.
Right. And kind of the premise for those therapies is they're monoclonal antibodies directed specifically at these targets.
Correct.
But not every treatment out there is a monoclonal antibody. So what other ways are there to affect the inflammatory pathway, these cascades, without, what are some of the other therapies out there that don't involve monoclonal antibodies?
All right, well, let's start with the monoclones first a little bit. I mean, the nice thing is that there's two drugs that target 17A and 17AF, right? So the secukinumab targets 17A, bizakizumab targets 17AF. And that's important because there's an article that was just published in the British Journal that in the dermis that surrounds the follicle, there's huge amounts of 17F being secreted by the skin around the follicle, which is an upregulatory, drives more inflammation. Okay. So that's important. But some people can't tolerate this drug. So we know that 17A, which is also secreted by dendritic cells, will drive inflammation. Now, you have the 17A, 17AF. They'll all interact and also upregulate TNF, which is also secreted by some of these dendritic cells. So if someone can't tolerate the 17A or the 17AF drug, at least we have the TNF inhibitor to fall back on. So when we're looking at drugs outside of the biologics, right? So I know that right now there are some clinical trials in the pipeline, and the next generation of drugs are going to be the JAK inhibitors. We don't have a JAK inhibitor oral FDA approved yet for treating HS. I've heard some scuttlebutt that there's things in the pipeline. There is a clinical trial going on. It's going to be starting, I think, here within the next month or so with a topical JAK inhibitor.
Right.
Ruxolitinib, which is marketed as oxalorid. It's a JAK1/2 inhibitor, and it's going to be used for mild to moderate disease, not the severe where people have hypertrophic acute scarring and 100 abscesses, but more with the follicular occlusion and occasional papules.
Right.
And that's a topical cream. It's already got the FDA approval for things like eczema and vitiligo. So it's not, it's not like the first scene in Hamlet where the three witches are brewing something and taking the wing of a bat and the eye of a newt and putting it together and saying, here, try this. So it's not anything like that. So this is already an approved drug, looking at it for an unfulfilled need. And, the theory with HS is if you can intervene early and catch things in the mild to moderate stage and not let people go to that severe stage, you can hopefully decrease disease progression and at the same time decrease morbidity.
So in the case of using topicals, these would be just at specific sites, affected sites, or do you see that it might have some greater systemic absorption that would?
I'll have to check with the medical science liaisons to see what the degree of absorption is. My overall impression is that I don't think you can be getting enough to get a systemic pop from the drug. I know.
Right.
I think that it's just more for localized absorption.
Cool. Maybe you could talk a little bit about JAK and JAK stat and what the heck is that?
Oh, JAK stat. All right. Wasn't it a song by the Rolling Stones? No, it was
Jumping Jack. Yes. Yeah. There you go. Yeah.
Right.
That's right.
Somebody got that wrong on Jeopardy last night. They asked, the final question was, what band got the best new performing, or it was the quick category was Grammys. What band got the best new performers in the 6th Grammy, and then the 35th and the 67th? And of course, one person put the Rolling Stones. It was the Beatles. Okay. I'm a big Beatles fan.
Okay.
So of course it was the Beatles, that. So anyway, JAK stats has absolutely nothing to do with the Rolling Stones. So, all right. So I'm going to have to draw.
Okay. There we go. I was hoping you were going to pull that out now.
Yeah. It shuts me up. Right? So if I'm drawing and I have my back, I can't be talking, right? All right. So everybody get your cup of coffee and start waking up. All right. So here we go. So let's pretend that this is a cell. And let's pretend for the sake of argument that this is what we call a Th17 cell.
T helper 17 cell. That's part of the immune system.
Right. There are mainly 3 classes of active cells and inflammation for our purposes, right? Th1 that drives the type 1 pathway. Th2, which drives the eczema pathway, interleukins 4, 13, so on and so forth. And then the Th17 cells, which drive the intercellular IL-17 pathway.
Right. We talked about that in psoriasis as well. That was
right. That's the main psoriasis. So we're going to pretend that this lousy drawing of a chocolate chip cookie is really a Th17 cell. And if you in your mind's eye visualize like a beach ball with the port that you put your mouth on to blow the beach ball up. So that port is what we call the cell receptor. So the receptor will bind circulating things that float in the bloodstream, right? So in this case, these things are interleukin-17 molecules, which act as an antigen. So what's an antigen? Something that stimulates a reaction, right? So the antigen, the 17 antigen, binds to the receptor. And when that antigen binds to the receptor, it activates the receptor. So that's a separate 1 hour lecture I'll employ, but let's just say it activates the receptor. And in the course of activating the receptor, there are these little enzymes that sit on the receptor, kind of like if you picture a stick with a glob of honey on it. The glob of honey would be the JAK enzyme system. Okay, so when these enzymes get activated, there's another set of enzymes within the cell called STAT, S-T-A-T, signal transduction or translation. They will automatically join together and then move to the cell nucleus, where they induce upregulation of the inflammatory molecule.
Right.
So the way I like to describe it is the receptor gets activated. So in other words, the catcher's mitt has caught the baseball. All right. So the baseball being the antigen, the catcher's mitt's caught the baseball. And in the course of catching the baseball, instead of bringing your arm back and throwing the ball, the receptor gets activated, stats join together. I'd like to say boy meets girl. They run off to a nice happy place, which is the nucleus, and they make this interleukin 17.
The baby comes out. Okay.
Right. And that's what drives the inflammation that we see pretty much in hidradenitis as well as psoriasis.
Right. So right now you could look at that and say, okay, well, there's two things you could do to affect that. One would be to block IL-17 with an antibody,
which is what we do.
Or we could go back and look at some of these intracellular mechanisms and look at that and think that might be a really good opportunity because, thinking about JAK, what some of the bad actors that JAK produces, and we already talked about IL-1, TNF. It's a long list of cytokines that JAK produces, not just IL-17, but it produces a wide variety of bad actors there.
As they'd say, the whole enchilada.
Well, what would be the potential downside if you shut JAK down altogether? Would there be any necessarily downside?
Yeah, I mean, all drugs have side effects, right? Otherwise, they'd be sold in the candy counter. So when you're blocking JAK, there's all sorts of things that you have to be, cognizant of, right? JAK inhibitors affect certain blood counts, platelet counts, lipid profiles. The main thing that we worry about, particularly in people over the age of 65, and this is more with the pills. This isn't really with the cream. This is more with the pills. Although the FDA has mandated a class-wide warning, even with the cream, that we have to be just as vigilant. But the reality scope is people are much more at risk to severe side effects from the pills than they are from the cream, right? So do we worry about deep vein thrombosis, pulmonary embolism, cardiovascular disease. I just reviewed an article yesterday, came out in May, Journal of Clinical Allergy and Immunology, where it showed that most of the time when you're on these pills in younger people, the side effect profile is considered manageable. When you get into the over 65 cohort, these drugs have to be used appropriately, right, with moderate to severe disease, with a good history, good physical exam, making sure that there's no predisposing factors, and used with caution, and it's our obligation as learned intermediaries to transmit this risk benefit to the patient and their potential surviving spouse, depending on the circumstance.
Right. And to be clear, when you're talking about oral medications, you're specifically referring to the JAK inhibitors.
Oral JAK inhibitors.
Okay.
Correct.
Right.
Correct. So, I mean, they're helpful. They're great.
What would be a few
amazing drugs?
Examples of that, just so people might have heard.
Severe atopic dermatitis. There are several drugs already approved, FDA approved, that are JAK inhibitors. And they're game changers for people, they're life-changing drugs. That's where in derm we use it the most. Now, the topical, which is the same one that we're going to be doing the clinical trial on for topical hidradenitis, mild moderate hidradenitis, the topical is a great drug. It's a great drug. We use it for atopic dermatitis and vitiligo. It's been a huge game changer for vitiligo. I mean, we had nothing that worked for vitiligo, zip, zero, and nada. And, up until about 2 or 3 years ago, people came in with vitiligo. The spiel they get from me is, hey, if it's been there longer than 2 years, good luck.
Right.
Well, we've turned that around, with the topical JAK inhibitor, topical ruxolitinib. We've got people repigmenting. And it's amazing. It's nothing short of amazing. And hopefully we can achieve the same thing in mild to moderate hidradenitis by using the topical JAK without having to get into some of the systemic concerns.
Right.
It's FDA approved down to age of 12, so it's appropriate for adolescents. So hopefully this will be a nice addition to the armamentarium.
Right. Well, let me ask you an investigator question, because occasionally patients will read about this and say, hey, we know that this topical works for this condition and this condition. Why can't you just prescribe it for hey, this other condition, right? Why can't, if it works for vitiligo and atopic derm, hey, just write me a script for my HS. Why can't we just do that?
It doesn't have the FDA approval. There's no scientific data. There's no randomized clinical trials that says, hey, it's going to work.
Right.
And these things are expensive and the side effect risks. And that's what I mean. Everything has to be used appropriately. And that's the beauty of doing the randomized clinical trials. So that we can know that we're giving this drug to this for a good reason.
Right.
With an anticipation of results.
Right. Now, of course, as investigators, we have a certain level of reassurance when we are already familiar with a medication or a compound and say, okay, we've got a lot of experience with this, but you're understanding we're looking at that in a different application. So you're right. You can't just go and decide. You shouldn't be just going and deciding you're going to treat people without having a good understanding about approval cost is
going to go off label and just shoot from the hip. I mean, usually you want to do a literature search first and just make sure that there's some appropriate literature. Like, for example, androgenetic alopecia. Well,
for those who didn't see, we're all pointed at our relatively hair-free scalps. I'm like,
so like for androgenetic alopecia, there's and I had this discussion with at least 2 people this morning, right? Off-label use of low-dose minoxidil. It works. It's great. Is it quackery to use it because there's no FDA approval? No, the drug went generic. Or once a drug goes generic, no company is going to pony up the money that it costs to run the randomized clinical trials and go through the FDA loop and hurdles. Okay, fine. But you can pull out 10 or 15 articles, which there are, that show, hey, this works and here's the side effect profile. So you're not just making something up. And it works. It works well. There's risks when you get over a certain dosage. But for by and large, low-dose drug for guys and young men that have hair loss, it's a great drug. People with alopecia areata, it's a great drug. It works. Here's your side effect profile. But you're not just making something up. You've done the literature search. You pulled 10 or 15 articles. You've read the risk-benefit ratio, and you can have an intelligent discussion with the patient. So that's the difference between just saying, yeah, let's just try this. I mean, 40 years ago, you could do that, But what was this joke that I heard? It's not a joke. There was a story back in the mid-1970s that the way that methotrexate got the approval from the FDA for psoriasis. A group of dermatologists went up to the FDA and said, we'd like to use this for psoriasis. Okay. That won't happen now, boys. Well, that's not happening anymore. But half a century ago, that's what people did to start using drugs. Hey, this worked. I used it on a dozen patients. Everybody's doing great. Yada, yada, yada. Let's get the proof. Okay, fine. That doesn't happen anymore.
Right.
So like when we do this trial, we'll be one site. There are multiple sites that have been doing the HS trial. And it's randomized. So we don't know what cream the person's getting because that's what we call blinded. We don't know what person's using. And we look at the results. And we don't know. So the results can't be tweaked. There's no cheating in the system. It is what it is. It's not what it's not.
Right.
If it works, great. If it doesn't, back to something else.
Right. And to be clear and full disclosure, we don't have financial interest in that company. So for us, as an unbiased investigators, we just want to get to the truth, and
which is what science is.
Right.
It's a exercise in empiric skepticism to search for truth.
That's right.
Right.
Right. Anything else you'd like to add to your JAK stat?
So, yeah, I mean, I think we covered the JAK stat basis, right? JAKs get activated, activate stats translocate to the nucleus, and upregulate cytokine cascade. So going back to HS, right? Let's go back to HS, because there's some cool things about HS. So from my readings and my thought process, HS, I think, is a two-phase disease, and that's why it's been so challenging to treat, right? So you have the initial inflammatory phases, which is when people come in with the draining tracts and the big tender lumps and bumps, right? Mm-hmm. What we call abscesses and nodules. And that's really driven by 17A and 17AF, at least based on what we see on current research levels. And then what happens is it transforms and turns into this scarring process, which can be quite severe. I mean, some of these scars are so bad that people can't lift their arm if it's in the axillary crease, or what we call the armpit. Mm-hmm. They have a restriction of leg movement if it's in the groin. And that, based on what I've read, seems to be a different set of chemical mediators. That seems to be a little bit of interleukin-1 and transformation growth factor beta. That's trying to, for some crazy means, trying to get the skin to recreate the epidermis inside the dermis, inside the outer layer and the lower layer. Why would it be doing that? You know, the computer system is misprogrammed, obviously. So the thinking is that if you can shut down the inflammation in the 17A, 17AF phase, you don't get to the interleukin-1 transformation growth factor phase, so you don't get the big scarring. And that's what we're really trying to prevent.
All right. So you're trying to, back to what I meant when we were looking at your drawing, I said, thinking in terms of trying to treat things more upstream, right? Try to prevent as much of that, the inflammatory cascade.
Exactly.
Yeah.
And it'll be really cool to see if the topical JAK can do as well as some of the monoclonals. Now, again, the monoclonals are for the more severe disease.
Right.
You know, but it'd be really interesting to see how much progress we can make with just the topical. That'd be really cool.
Right. Well,
this is my new picture, by the way.
I like this.
Snowstorm and
I like that. You've really accurately recreated that. One of your many talents, right? Educator, researcher, clinician, and
snowstorm and house.
And
right.
That's right. And that's right.
Yeah.
Well, so Mike, get to that point in the interview, and I say, hey, any question you wish I'd asked, or anything you'd like to add to what we've set up to this point?
Well, restaurant review.
Okay. Good. Okay.
Okay. This is the highlight. This is what everybody's waiting for. I had dinner the other night at M Brothers in Vail. I've got to tell you, it was really good. Really good. I'd give it a 5-star. You know, the same people that do Matthews and do Maduras, they have M Brothers and it's the Mayo Clinic. Absolutely great.
Okay.
Absolutely great.
Do you got a recommendation?
I had the steak.
Okay.
For all you vegetarians, for all you people that are watching cholesterol, I had the steak.
Okay.
It was pretty good.
Okay. So my turn. Okay, I'm actually vegetarian, so you're looking right at one. How about that?
Wait, if you eat steak, you're an indirect vegetarian, right? Because the steak ate the
There you go. It's right. It's through second or third hand. That's right. So I'm gonna put a shout out for the Floridian in St. Augustine. Okay. I like this. It's a great kind of that Florida Southern comfort cooking. It's got a lot of great vegetarian options, and for people who eat seafood, lots of great options. So I'm a go-to all the time there. The Floridian.
Good to know.
Yes, sir.
All right.
So what's our next topic of discussion going to be in the derm world?
What do you want to talk about?
Well, we're talking about our bald heads, but until we got to come up with something better to help that.
Talk about alopecia.
Okay.
Talk about the march of the hair follicles.
Let's do that.
Sounds good.
Cool, man. All right.
Sounds good. Hair today, gone tomorrow.
There you go.
All right.
Thanks for joining the MedEvidence podcast. To learn more, head over to MedEvidence.com or subscribe to our podcast on your favorite podcast platform.